right. Now that you've had kind of the refresher on CPR and basic life support from part one of this lecture group, now we'll kind of get started talking about what you're going to experience more, which is advanced cardiovascular life support. So this is kind of the process that we follow every time that there's a medical emergency called in the hospital. So everything that you kind of discussed in part one is really those like kind of first initial moments until the rest of the code team gets there. But it's a lot of hospital medical emergencies really revolve around understanding the ACLS algorithms and identifying the dysrhythmia or the arrhythmia that's occurring, and choosing the proper treatments with drugs, medications, and defibrillation. So advanced cardiac life support is really going to be using kind of additional equipment to support that oxygenation and ventilation, different monitoring tools to be able to assess things like the dysrhythmias, so we'll need an ECG monitor on. Establishing a route to deliver different types of medications. So IVs or IOs are typically the primary routes that we use nowadays. And then selecting the correct pharmacological agent and electrical therapies to give to help the patient correct the patient's dysrhythmia and kind of get their hearts restarted and functioning again. So again, your primary role in ACLS is to support oxygenation, and then establish and maintain that airway and provide that ventilation. So you're going to be putting the patient on 100% oxygen. You're going to be assisting with the intubation, securing the airway, and then providing ventilation to the patient during. Okay. So how do we best support oxygenation? Remember, the patient is going to have zero cardiac output except for what we're giving them through compressions. And there's going to be a lot of pulmonary shunting going on, meaning ventilation is getting to alveoli that are not going to be being perfused because the heart's not pumping. So these things are going to lead to a lot of tissue hypoxia. If the heart tissue is not receiving oxygen, it is not going to get out of its bad rhythm and start behaving itself and start pumping again. So I need to fix hypoxia. So I need to make sure that I'm delivering the highest concentration of oxygen possible to the patient. I'm not worried about oxygen toxicity at this point. I am just going to be giving them 100%. If it's an adult or pediatric. If it is a neonate, there are certain circumstances where you would choose something less than 100%, and we will talk about that further when we get to neopeds, your final semester. You're going to be looking to put in advanced airways, and before you can put the advanced airways in, you're going to be utilizing pharyngeal airways to support that airway patency and improve that ventilation. So again, your two types are your oral pharyngeal airway, which is the airway of choice in most circumstances, or you can use a nasal pharyngeal airway, and these are going to be reserved for patients that have have a risk of seizures, presence of seizures or risk of seizures, or if they have facial trauma that makes it difficult, like a broken jaw, that would make it difficult for an oral pharyngeal airway to be effective. Excuse me, sorry. Then you should be, as long as, trying to think about how I want to say this. As long as a patient is being adequately ventilated, the priority during the code where we're actually doing CPR is not to intubate the patient, okay? Because intubation a lot of times can interfere with compressions. I do not want to stop compressions to intubate the patient, but I also need to make sure there's adequate ventilation. So using those pharyngeal airways to make sure I'm ventilating properly so that I'm not, stopping compressions to intubate is kind of the thing you should be thinking about. Now, in real life, we do tend to intubate the patients early on because the doctors do want to make sure that the patient has a patent airway, is getting oxygen ventilated properly. In the hospitals, this is usually the right choice because we usually have skilled intubators at the bedside who can quickly insert an airway with minimal interruptions to compressions. So the other benefit of intubating is that I can deliver those ventilations without having them stop compression. So there's no longer going to be doing 30 compressions in 2 breaths. Now the compressors are going to be just doing continuous compressions at least at 100 beats per minute, compressions per minute. And then I'm just going to be squeezing that bag every 5 to 6 seconds. Okay. So this really ensures that adequate ventilation. The other benefit of this is that now I have a tube in place that's got a cuff that's inflated, and then my lower airway is going to be protected from aspiration. Less air is going to end up in the stomach, but still, patients can vomit during codes. They frequently do. And now that I have that cuff in place, I'm going to be less likely to have that risk of aspiration. The other nice thing about an ET tube is that it helps me suction the patient. So if there are a lot of secretions coming out, it helps me facilitate suctioning during the code. Last one there before I get off the slide. It also provides a route for some medication administration. Some medications can be delivered down the ET tube if you do not have an IV in place. This used to be more common where we would dump like epinephrine down the endotracheal tube, but now IOs are so accessible, interosseous lines, where we're actually putting the catheter right in directly into the bone. That those kits are readily available. Nursing staffs are really well trained in using them, so that is usually the preferred route of doing this over dumping meds down the ET tube. So we no longer usually use the endotracheal tube to deliver medications during codes. So after intubation or during intubation, we need to make sure that we're not interfering with compressions. This should not be practice time. If it's a code, this should not be somebody's first attempt ever at intubation. It should be performed by somebody who knows what they're doing to minimize those interruptions to chest compressions. After the patient's intubated, it's really important, instead of using the colorimeters, it's really important during resuscitation efforts to put them on waveform capnography for CO2 detection rather than just the colorimeter. And why that is because these waveform capnograms don't tell me just that the patient's ventilating. So each of these humps, again, is exhalation. So that tells me that my ET tube is in the right place. But how much is being exhaled tells me how well the lungs are being perfused. So if I'm doing compressions and I'm doing effective, good compressions, I should see a minimum reading of 10 milligrams of mercury on my CO2 waveform. Okay, if it falls below 10, that tells me that the person that's doing compressions isn't doing it hard and fast enough. So if I'm in a code situation and I notice the capnogram goes down to a reading of like 6, I would give that constructive feedback of, you need to push harder, you need to push faster, or do you need to change? Do you need to switch? Because again, CPR is super tiring. It also is one of our first indications that the patients had a return to spontaneous circulation. So the term ROSC is what we use to tell us when the patient's heart starts beating on their own again. And the first kind of indication that that's happened is on the CO2 waveform. When I see this sudden spike in my exhaled CO2, that means that my lungs have, are perfusing better. So CO2 is getting dropped off to the lungs to get exhaled, and I'll see the CO2 monitor increase to about above 40, and that usually indicates that I have my heart's started back up and had that return to spontaneous circulation, which we call ROSC at the hospitals. Bag valve mask devices, a couple other points about these. Self-inflating bags are used to deliver somewhere between 400 to 500 milliliters volume over a second. Okay, so that is usually adequate for any normal adult sized person. Okay, it's important to deliver the breaths very slowly, so over a second. You're going to deliver those 2 breaths during CPR and then resume with your 30 compressions. Okay, unless the patient's intubated. So couple reminder tips that we talked about already about bag mask devices is to achieve the highest possible FiO2. You need to have some type of oxygen reservoir on the bag. You need to be using high enough flows on your O2 flow meter, so 10 to 15, so you turn it all the way up. You need to make sure you're not using excessive tidal volumes. And you need to be delivering them slowly. And then you want to make sure that you're not hyperventilating the patient, because as you squeeze that bag really fast, you're not giving that bag time to refill with oxygen, and your FiO2 is going to decrease. So when you're troubleshooting your, no, sorry, one second. So when you're troubleshooting your resuscitation device, most common problems, if you don't see a good chest rise or your patient's good chest rise with the bag valve device, a lot of times the most common problem is equipment failure. So I always like to just do a quick test of my equipment before I hook the bag up to the patient. And I do that just by holding kind of the bag in my hand, and I'll include the bag and I'll try to squeeze the bag, and I shouldn't be able to squeeze it then, because that tells me that I don't have a leak. And then when I take the occlusion off and open the bag up, I should be able to squeeze it well, and air should come out of it. And I just, that takes me like half a second to do, but it's important because then I know my equipment's working properly. So, then I can troubleshoot issues with the patient if I'm not getting good chest rise, or I can troubleshoot issues with airway patency if I'm not getting good chest rise. Gastric insufflation, again, before the patient's intubated, is another major complication of this. You want to use low flows. I could also create barotrauma by squeezing the bag too hard, and that hyperventilation is going to cause decrease in venous return and decrease cardiac output. Okay. So, restoring cardiac function is the kind of the goal of ACLS. So before, with BLS, we were just concerned with ventilation and perfusion, but in ACLS, we're really going beyond that, and we're looking to identify the underlying cause of the arrest, fix it, and then restore that cardiac function with medications and defibrillation. So in order to do that, I need to have the patient on an ECG monitor during CPR to identify the underlying rhythms. So some of the rhythms you might see are rhythms like supraventricular tachycardia, or those tachycardic rhythms. So SVT is one of them. You can have a flutter, a fib. Those rhythms are tachycardic rhythms that will sometimes need a procedure called a cardioversion to correct. Those rhythms all will have a pulse associated with them. So I will feel a pulse. My patient might be responsive in those rhythms, but a lot of times, because that ventricle is beating so fast and it's not having time to refill in between beats or contractions, the patient is going to be very hypotensive and symptomatic and unstable. So we would want to cardiovert them out of that, which is a synchronized form of defibrillation, which then kind of resets the heart so that it can kind of hopefully go back into an organized rhythm and function the way it's supposed to. The next one, ventricle tract tachycardia. This can have a pulse or cannot have a pulse, and this is when the heart tissue is kind of gotten agitated and is not contracting properly. So again, it's not kind of a perfusable rhythm. My patient is going to be symptomatic, or they're going to be unresponsive without a pulse. And if we don't correct that, they're going to end up in ventricle fibrillation, where the ventricle is not pulsating at all, not contracting at all. It's just fibrillating. And then finally, I could end up in PEA, which is pulseless electrical activity, or asystole. So going back through the rhythms and giving you a little bit of a refresher, and I know you guys went through this in CP Phys, but can't go through it enough. Rhythms, EKG rhythms are the bane of many, many, many respiratory therapists' existence. I hated EKG rhythms for a very long time and did not want to have to learn this. This was one of those things where I felt like very early in my career that this was not, I did not want to be responsible for reading these because I felt like it just seemed very hard. But then I found a couple tricks along the way that made my life a lot easier in understanding this. And I'm hopefully going to be able to impart some of those to you guys so that this is not as scary and seems a lot easier. So first off is sinus rhythm. And this is a nice image because this kind of shows you what's happening in the heart when your patient is in sinus rhythm. So sinus rhythm means that you have a P wave, which is when your atria depolarize, meaning that your atria gets an electrical impulse that's telling that atria to contract. So the top of your heart is contracting in that P wave. Then that P wave should be followed shortly by a QRS complex. This is where you have the ventricle contraction. So that electrical impulse goes down, passes down through the AV node into those Purkinje fibers, causes a contraction of the bottom of the heart, the ventricles, and then blood is pumped out of the heart to either the lungs and the aorta to the rest of the body. So this is your ventricle contraction is associated with this QRS complex. This pause between your P wave and your QRS complex should be very short, but that pause is necessary because that allows the atria to fully contract and empty into those ventricles. So those ventricles are completely full. That's called preload. They're full of blood so that when they contract, they're getting a full dose of blood ejected out of that chamber to the body. Okay, if this pause doesn't happen or doesn't happen appropriately, you're not getting enough time to fill these ventricles, so you're going to get like a half squeeze of juice out of the ventricles with each beat, and that is not going to give you a good enough blood pressure. Okay. So after the QRS complex, you have a little bit of a gap here, and then this T wave is when your ventricles repolarize, meaning that the electrical activity goes back to baseline in the ventricle, and the heart then is ready for the next impulse, stimulation, contraction. Okay, so that is considered sinus rhythm when you have all of those components happening at the correct measured distances. So supraventricular tachycardia, this is tachycardia that happens, and it's usually not happening because of the ventricle. Okay, so we know the SA node is a pacer of the heart. So your SA node is what is going to make the heart beat fast, which is this one up here. Okay, so when this impulse does not go from the SA node down to the AV node, down the Purkinje fibers, like if it goes in this weird cycle here, this irregular spiral here, where the SA node gets stimulated, bounces here, but bounces back, then I'm getting two stimulations of this. That is going to make the heart beat twice as fast as it's supposed to. So these supraventricular tachycardias happen and your heart rates with these are going to be excessive. They're going to be really fast. So typically this happens, like sinus tachycardia can happen anywhere up to about 140 beats. But once you get above 160 beats per minute, then it's very safe to assume you're in some sort of SVT. Another thing to look at when you're looking at rhythms is the first thing I ever look at is my rhythm regular or is it irregular? Meaning that my R to R interval, the distance from this blip here to this blip here, is that happening at the same distance for each beat? Okay, because that helps me kind of differentiate between arrhythmias fairly easy. So if it is regular, then I know that I am dealing with like SVT or a flutter, but atrial fibrillation would be irregular. Okay, meaning that this R to R distance is not happening at the same space. It's, I might have one here and two boxes in between before I have another one, and then one's right after it, and it's just kind of, it's not marked, those lines aren't marching out at the same distance. Okay. So like I said, what the concern with this is those ventricles are not having enough time to fill, so my cardiac output decreases. Blood then starts getting backed up. My heart function starts to go down. Blood starts to back up into the lungs a lot of times, so you can end up having pulmonary edema with this as well. And patients also have a lot of tissue hypoxia because of that decreased cardiac output. Excuse me, I just yawned. So treatment for this, your book mentions carotid artery massage, which we talked about in patient assessment back in survey, which is not usually recommended unless the patient's young, because if you do this, where it's like a procedure where you're rubbing the carotid artery in the neck, you need to know what you're doing. Two, if you do this on somebody who's old, you might like dislodge clot or something and give the patient a stroke. So it's mentioned in your book. I do never see anybody do that because the risks are too big. And what that is supposed to really do is it's supposed to like simulate this vagal response. So doing a vagal remover that's got that Valsalva response, which is when that happens, it's kind of just does a little bit of a factory reset on your heart, makes you your heart rate kind of slow down, and then hopefully that slows it down enough that then it kind of goes back into what an organized rhythm and what it's supposed to do. So the best way to do a vagal maneuver is, typically you'll tell the patient to bear down. But paramedic taught me this once, which I thought was a good maneuver because it's just like, well, you tell somebody bear down and they're like, I don't even know what that means. Like, how do you describe bearing down to somebody? So he would give a patient, he'd take the plunger out of a syringe and have them breathe through that narrow opening of the syringe. And that would create enough back pressure that would perform that bear down vagal maneuver, kind of force the patient to be doing that maneuver and bearing down. So I'm like, oh, that's kind of a good idea. So it's a little bit easier to instruct a patient to do that than just kind of say vagal maneuver or bear down. If those things don't work, and those are things that we try on patients that are stable. So if you are unstable and you're in SVT, you're not going to waste your time doing a vagal maneuver. You're going to jump right to cardioversion or meds. But if your patient's stable, you can try a vagal maneuver. If they're unstable, meaning they're hypotensive or they've got a decreased level of consciousness, they're confused, you are going to go right to meds or cardioversion. Cardioversion is what you should probably do first if it's available. Like if it's readily available, then just cardiovert them. But most of the time, cardioversion is not readily available. It's not, that code card's not in the patient's room. The meds are quicker to grab. So you would grab a medication called adenosine. So I don't know if this is like healthcare meme, I feel like, with adenosine is like, because essentially it's like the factory reset of the heart. It's the medical version of turn it off and turn it back on and see if that fixes it. So adenosine is going to stop your heart. you give 6 milligrams of adenosine IV push, and your patient on the monitor, you will see a flat line on the monitor for, 2 seconds. And then you will see the heart restart back up. So adenosine stops the patient's heart. That is what it does. And the hope is the same thing with when your printer doesn't work or your computer's not working. I turned it off, I turned it back on, and I'm hoping that fixes my problem. And sometimes it does. They go back into an organized rhythm and the patient is fine then. If it doesn't work the first time, you can give a second dose. So you'll give 6 milligrams the first time, IV push, rapid IV push. And then the second time, you're going to give 12 milligrams. Again, that will stop the heart for a brief period of time, and then it will restart in what we hope is an organized rhythm. If those 2 doses don't work, hopefully by that time you have the code cart there, you have the defibrillator, you've got the pacer paddles on, for the defibrillator pads on the patient, and you can perform a synchronized cardioversion, which we're going to talk about a little bit later. Ventricle tachycardia. This occurs when, when you have like kind of an irritated focal point in the ventricles that's discharging at a rapid rate. So this is where you have this, kind of a cycle of the stimulation. This impulse went from the SSA node to the AV node, down the Purkinje fibers, and then it keeps refiring and refiring and refiring and refiring in the ventricle. So this ventricle just keeps pushing the button of that ventricle saying, hey, keep going, keep going, keep going, keep going. And you're going to have these premature ventricle contractions, and the same symptoms are going to happen with this. Is you're going to have the patient not have enough time for their ventricles to refill with blood, so they're going to have low blood pressures. They're going to be have confusion, loss of consciousness, things like that. So if the patient's stable, you can try amiodarone. Amiodarone is an anti-arrhythmic medication that is given both in the ACLS algorithm, and also can be given in stable patients with ventricle tachycardia that's generating a pulse, to try to get them out of this rhythm and get them in more an organized rhythm. Okay, so you can give it in a stable patient, IV drip over 10 minutes. In an unstable patient, you're going to do that synchronized cardioversion if they have a pulse. If they do not have a pulse, they're automatically in the unstable category, and then you're going to be doing defibrillation, epinephrine, and amiodarone in the ACLS algorithm. Okay, so this is like this ventricle fibrillation and pulseless VTAC. What's happening here in VFib is you have this rapid, sustained, uncontrollable depolarization of all the ventricles. So all over the ventricle, like this is like these, those channels are open. The muscular cells are getting stimulated, but it's not causing an actual contraction. So typically on the EKG rhythm strip, you're going to see just kind of a bunch of mess, where you're not seeing any like defined QRS complexes or P waves or T waves. They're very low amplitude usually. They just kind of, they look very disorganized. I feel like that's the best way to describe it. It's just not, you can't really identify anything. When you look at this rhythm strip, I'm like, I can't see anything. I don't see a P wave. I can't tell which is a P wave, a T wave, a QRS complex. It's just a mess. Then you know you're VFib. So for the treatment of this, once you see VFib, your first thought is, I need to defibrillate this patient as quickly as possible. So defibrillation is giving energy to the heart again, to get them back in an organized rhythm. This is also called unsynchronized cardioversion. Okay, so we'll talk a little bit more about cardioversion later on, but defibrillation is using a lot more energy than cardioversion, and it doesn't have to be, because there's no defined, like, organized complexes at all on this. I'm not syncing to anything. I'm just giving them the energy, delivering energy to the heart to try to restart it. So that's my first priority. My second priority is to start giving epinephrine. Epinephrine needs to be given 1 milligram every 3 to 5 minutes. So my first drug, if I see this happen to my patient, I'm going to say, pause CPR, see the VFib. I'm going to say shock advise, shock the patient. They're going to shock the patient. And then I'm going to say give 1 milligram of epi, IV push, rapid IV push. And then they follow that up with a 20 cc flush. Then I'm going to go, and while I'm giving that medication, we are doing 2 more minutes of high quality CPR. At the next rhythm check, which should be 2 minutes from the last defibrillation, we're going to pause again, look at the rhythm. If I'm still in VFib, I'm going to defibrillate again, resume CPR, and give amiodarone. So amiodarone is that antiarrhythmic medication that is going to help hopefully correct this disorganized rhythm in the ventricles. The dosage for that is 300 milligrams. I'm going to give 300 milligrams, rapid IV push, followed by a 20 cc syringe of saline. Do those 2 minutes of CPR to circulate that med. At 2 minutes, I'm going to do another rhythm check. If I'm still in VFib, again, I'm defibrillating. Now, it's been 4 minutes since my last epinephrine, and I'm going to give epinephrine again. And I'm going to keep doing this sequence until the patient either responds and comes back and we achieve ROSC, or return of spontaneous circulation, or we decide as a team with the doctor to call the code. The other treatment medication that you can use in this algorithm, you're always going to use epinephrine, you're always going to defibrillate, but you can choose to use lidocaine instead of amiodarone with these patients. But if you are doing lidocaine, then you're doing lidocaine, and if you're doing amiodarone, then you're doing amiodarone. So both of those medications are available for ACLS, for VFib. Okay. When you, if you can't get your patient out of VFib, or we don't identify the underlying cause of the issue, patients can end up in something called pulseless electrical activity, or the other one is asystole. So pulseless electrical activity, there's 2 different types of it. So there's a pseudo PEA. This happens where there's electrical activity in the heart, but the heart muscle is squeezing, but not squeezing strong enough to pump any blood. So you're not going to feel a pulse. This can happen a lot of times in patients that have like a tension pneumothorax. So the electrical activity is there and the heart is trying to squeeze, but because of all the compression of the free air around the heart can't squeeze very well or very strongly, so you're not going to get any pulse generated. So that's an example of like a pseudo PEA. A true PEA is where there's electrical activity, but the heart muscle just doesn't even attempt to contract at all. And that can be because the heart tissue is damaged. So like with like a myocardial infarction, the heart tissue is damaged to the point that the heart muscle just says, yeah, I quit. So the primary treatment for this is to do that uninterrupted CPR. Because there's electrical activity in the heart already and it's organized and it's a issue with the heart muscle contracting, I'm not going to defibrillate this patient. I'm just going to be giving a vasopressor, which is epinephrine. Epinephrine, the mechanism action for epinephrine is not only vasopressor, but it also increases the heart's contractility. So it's going to make the heart want to squeeze harder. And then again, I need to, with any of these arrhythmias is try to figure out what the underlying cause is. So we're going to talk in lab about H's and T's. So you have 5 H's, 5 T's. And let me see, I think your book lists them. They kind of list them on page 1010 or 807, which it's not listed how you usually see it in ACLS, but you kind of get the gist. So your 5 H's are hypovolemia, meaning you have like low blood volume. Okay, so if you're hypovolemic, that means you don't have a lot of blood volume. I'm going to type these out on the slide so you can kind of see it. So your 5 H's are your hypovolemia. So to treat that, I would be giving fluids. So typically when we have a patient that's in cardiac arrest, to improve perfusion, they're hanging at the minimum saline or IV fluids to try to bump up the volume of blood the patient has to increase perfusion. Oh, sorry. Okay. Sorry, the dog has been barking a lot during both of these lecture recordings. Apologize for that. Hypoxemia or hypoxia. Okay, sorry about that. Fritz had to go in doggy jail for too much barking. All right. So hypoxia is when you have inadequate tissue oxygenation. So we need to make sure the patient has oxygen. So we fix that by manually ventilating the patient with 100% oxygen. We're also, by manually ventilating the patient with 100% oxygen, are going to fix the other issue that the patient might be having, which is hydrogen ion, which is a fancy way of trying to keep things simple by making this an H, but this is really acidosis. Hydrogen ion is a fancy way of saying that your patient is in acidosis. So you guys are learning about ABGs and ABG interpretation. So acidosis is when we have either too much CO2 in our blood where I'm not ventilating effectively, or too much fixed acids in my blood where my renal system's not working the way it's supposed to. And again, to fix this, I need to ensure that I am ventilating properly. So I need to to fix acidosis and hypoxemia, I need to make sure that I have adequate ventilation happening. So this is one reason why I do support intubating the patient, because then and putting them, bagging them with 100%, because then I know both of these H's are fixed. So I can kind of rule those out as another cause. So another H would be hyperthermia or hypothermia. Not hyperthermia. Usually it's not hyperthermia. It's usually hypothermia. Okay, so hypothermia would be hypothermia. There's a saying in medicine is like they're not dead until they're warm and dead, and that's because patients that are exposed to really extreme cold temperature, exposed to things, they can become hypothermic, and then after we've warmed them up, they usually have they usually kind of return to us. So hypothermia needs to be treated. So typically we do that with warming blankets, or they will warm the saline that they're putting into the IVs to try to warm the patients up a little bit more. Hypo or hyperkalemia. This needs to be corrected because potassium is a main electrolyte that is going to affect heart function. So if you have hypo or hyperkalemia, that can cause cardiac arrest. So this is usually, they might do a metabolic panel, a CMP, draw some blood during the code, see if it's a potassium issue, and then either give potassium. If it's hypo hypokalemia, you would give potassium. If it's hyperkalemia, they can treat that either, the only ways you're treating that is with dialysis or a ridiculous amount of albuterol treats hyperkalemia. But the jury's out on how effective that is. Okay, so now let's talk about some of our T's. So those are our 5 H's. Our 5 T's are going to be your thrombosis, pulmonary thrombosis, which is a fancy way of saying a PE, pulmonary embolism. So that's a blood clot that's in your lungs. Those patients need to go to interventional radiology to get that removed. I've rarely seen somebody who has a big enough PE to cause them to cardiac arrest. Those tend to not be very successful resuscitations because usually you can't fix it quick enough to save the patient. You can also have thrombosis and it be cardiac, which is a fancy way of saying an MI or a myocardial infarction or a heart attack. That is when you have the blood clot in the coronary arteries, which is the blood flow to the heart tissue. If that gets blocked, the heart tissue does not get oxygen and nutrients, and then that tissue starts dying off. If this is present, these patients need to go to cath lab to get that clot removed and that vasculature opened back up and blood returning to that heart tissue. So that's another T. Tension pneumothorax. As I mentioned before, this is kind of a pneumothorax. This is a common issue in every PEA patient I've ever seen is the culprit was a tension pneumo. Once you fix the tension pneumo, there's less pressure in the patient's chest and the heart should be able to start contracting again like it's supposed to. Another one is toxins. So this is the T way of saying drug overdose. So if you think that the patient drug overdosed on opioids, you would reverse it with Narcan. If you think they overdosed on benzodiazepines, you would reverse it with Romazicon. If it's anything else, you're on the phone with the poison control to figure out what the reversal agent is. Like people like to overdose on things like aspirin and stuff like that. They do activated charcoal for aspirin overdoses, and they actually give them PO mucomist, acetylcysteine as well to counteract aspirin overdoses. Not nebulize, but make them drink it. Not drink it, put it down their NGs. Okay, last T. I'm trying to think here. Cardiac tamponade. This is the pretty uncommon one. This is where you have fluid or air or something is filling up that pericardial sac. And to correct it, you need to do a pericardial centesis where they stick a big needle in your pericardium area and remove the fluid, just like you need to remove the air with a tension pneumothorax. It relieves the pressure around the outside of the heart, and then the heart can start contracting again. This would be, you should be worried about like cardiac tamponade for patients that like have had like blunt force trauma to the chest. That's usually in the history for those types of patients. Okay, so those are those underlying causes that they refer to them commonly as H's and T's that you should be thinking about during the medical emergency to try to treat and fix, because if you don't treat and fix it, then you probably aren't going to successfully resuscitate the patient. Right. Pharmacological interventions. So unless there is a central line already in the patient, so meaning that this patient's been hospitalized for a while, so they have a central line in place or a PICC line in place, you would typically nursing is trying to start at least 2 peripheral IVs to make sure that they have access and they maintain access during the code. If they can't get peripheral IVs in, they would choose to do an intraosseous, which is a device that catheterizes directly into the bone marrow, and you can inject the medications right into the bone, which is hooked up to your vascular system, and it's just as effective as a peripheral IV. So all the drugs that are given during ACLS are given rapid bolus injection. So you're pushing it quickly, and then they follow it up with a 20 cc bolus of saline flush, IV flush. A lot of times if it's a peripheral IV, they'll hold that extremity up to try to help have gravity, help move that medication back towards the heart so that it's circulated better, and hopefully can get be effective. There's a really good table on page 811 in your textbook that goes through each of the medications and the doses and kind of what that medication does for you. Like adenosine, like I said, that one's the one that stops your heart, and it does that by decreasing your the impulse conduction through that AV node. Epinephrine in here, it increases your heart rate, it increases that force of contractions, it causes vasoconstriction. So it's the kind of the main medication that we use during codes. Okay, so moving on to electrical therapy, and we are going to cover meds with this, and we are going to cover ACLS very in depth when you get to semester 4, because you have to take ACLS and become certified in ACLS when you take cardiac diagnostics with me in your 4th semester. But like I said, I just don't want you, this is just a brief overview so that you feel like you know what's going on if and when you go to codes this summer at summer clinicals. Electrical activity, there's 3 general types. There's unsynchronized, which is generally called defibrillation. So this is just a shock is delivered to the patient, and what that does is that depolarizes all of those cardiac cells simultaneously. So they're all going to be depolarized simultaneously. So then it kind of just hopefully resets the heart and gets it back in an organized rhythm. So it is an important treatment of both VFib and pulseless VTach. Typically, you're going to see mostly biphasic defibrillators nowadays in the hospitals. And so biphasic defibrillators, what that does is it sends energy from one pad to the other and then back. So the energy crosses both pads, crosses the heart twice. So it goes through the heart and then jumps back through the heart again. So you need less energy when you're using a biphasic defibrillator. So it's typically 200 joules for an adult. Monophasic defibrillators, I don't think I've seen a monophasic defibrillator in the hospital in years, but those defibrillators that electrical energy only goes one direction, so it's only passing through the heart once, and you need more energy then, so it is 360 is the recommended energy level for monophasic defibrillators. So synchronized cardioversion, this is when we use that shock is delivered during a specific phase of electrical activity in the heart. So it's synchronized to those R waves. And why that's important is because if you deliver the shock to a patient who has a pulse during that repolarization phase, that T wave phase of the electrical activity in the heart, you can stop the heart and then make them go into VFib. So you don't want to do that. So you want to make sure you're synchronizing it with the R wave. So this uses less energy because it's, this is a little shock delivered at a specific point in time to try to reorganize the patient. Um, uh, and we use it in patients who are unstable and have some form of tachycardia, supraventricular tachycardia. So it would be your SVT, your pulsed VTAC, your AFib, your A-flutters would potentially get synchronized cardioversions if they're symptomatic. Pacing is another thing that we haven't really talked about much, but this is something that happens when you have a patient that has a very low heart rate. So very, very slow heart rate. We need the heart to beat faster than what it is. So they will put, instead of having an internal pacemaker, we will do it externally. As you can imagine, with synchronized cardioversion, external pacing, the patient, if they're responsive, they're not going to really like you very much. This is an electrical shock. You're shocking the patient to get them out of this. This is going to hurt. So typically we will try to give the patients medications like pain meds, sedation meds for these types of procedures to try to avoid, help them with the discomfort of it. So the two primary types of pacing is, doing that, those pads on the patient's chest, external pads on the patient's chest. They'll put just like the same placements that we use for cardioversion. And these pads will send an impulse to the patient's heart to kind of get the patient's heart to then contract. It's going to use very, very low energy. And again, it's going to try to capture on those R waves on the rhythm. Transcutaneous pacing or external pacing is only used for a brief period of time, and then the patient's going to go to the cardiac cath lab to get an internal pacer placed. So monitoring during ACLS, again, we want to minimize the amount of the interruptions to chest compressions. So we want them to be less than 20% of the time. The chest, we have interruptions. So 80% of the time we should be doing compressions on the patient's chest during cardiac arrest. We want to make sure that our rate is good. We want to make sure our depth is good. We want to make sure we have good recoil. We want to make sure we're not having excessive ventilation. And we can use capnography to ensure that we have good perfusion to the lungs. So our capnogram should be reading at least 10 during CPR. Once it goes over 40, that tells you have ROSC. Once you achieve ROSC, you're going to start worrying about what you're going to do with the patient afterward. So aftercare for resuscitation is very important. We've just got the heart back started. You just had a really bad morning if you're that patient, and we want to do everything that we can to treat the reason for the cardiac arrest so it doesn't happen again, and to lessen any ischemia reperfusion injury. Okay. And that's a fancy way of talking about how the brain, if you think about the brain has a lot of metabolism that happens there because the brain needs a lot of energy function. It's a very needy organ. So when the brain's not getting oxygen, it's going to go through anaerobic metabolism, and it is going to produce a lot of free radicals through that process. Those free radicals are going to create increased additional damage and edema to that brain tissue. So when the brain then all of a sudden gets reperfused, those free radicals are going to get released, and then that can create secondary injury to the brain tissue after the initial incident of not getting what it wants and getting oxygen. So one way we help do that is to do therapeutic or targeted temperature management, which we're going to talk about in a couple slides from now. After we bring these patients back, depending on how long the patient was down, meaning how long their heart was stopped for, there's going to be different prognosis for the patient. So obviously you can imagine the longer the patient was without a pulse, the worse their prognosis is. So usually the doctors will have a conversation with the family members about kind of what to expect, other tests that we're going to be performing on the patients, follow-up wise, to just see if there's additional injuries to the patient's brain function and things like that, with the plan of care. So, and then just kind of discussing a little bit tentatively, like wishes about what the patient would want to have happen next. I can't say this enough. This is why it's really important. Don't make your poor family members make this decision for you, especially at the worst moment of their lives when they just, they're worried about, their family member. They love their family member. This is very traumatic for everybody. Don't make them make that choice for you. Advanced directives are a wonderful thing, and everybody should have them, no matter how young you are. um, So if the patient, after the resuscitation, we as RTs are going to need to make sure that we are putting them on ventilators, supporting their oxygen and ventilation. A lot of times they're going to be put on maintenance IV infusions. So a lot of times if we brought them back with epinephrine, they might be on an epi drip for a while, just to make sure that heart keeps going till we fix some stuff. And then we'll do a lot of continuous cardiac and hemodynamic monitoring with this patient. So these patients are going to go to unless they have to go to the cath lab or IR first, they're going to go to the ICU. They're going to be put on a monitor. They're typically going to get a central line so that we can monitor their hemodynamics status closely for the next little while, to make sure that everything's kind of stabilized. So post cardiac arrest patients, controlling that body temperature. As I mentioned, the next slide, we're going to talk about targeted temperature management. You're going to treat and identify and treat if there's any acute coronary syndrome. So you're going to be looking for ST elevation or depression on the EKG. So typically after we get the patient back from cardiac arrest, we're going to be getting an EKG, 12-lead EKG. We're going to get a blood pressure. We're going to be probably getting a chest x-ray for tube and line placement. We're going to be potentially going to CT or to check for any underlying issues that might be happening. We're gonna yeah, I think the rest are self-explanatory. So we're looking to reduce multi-organ injury. We're looking to be realistic with ourselves and our family members and the patient about the prognosis for recovery. And then a lot of these patients are going to have some form of rehab after this incident. Very rarely do patients go into cardiac arrest and leave the hospital the next day. There's going to be a little bit of recovery period. So targeted temperature management. This is also known as therapeutic hyperthermia or induced hyperthermia. It is a strategy that we use after cardiac arrest or for stroke patients or anybody that we think has not been perfusing their brain for a period of time. And the aim of it is to improve brain function, neurological outcomes. Okay, so there's been a lot of studies about this. So the initial trials with therapeutic hypothermia, which is what we used to call it all the time, we're back in 2002, which makes me sad because this happened after I've been a RT longer than this has been around. But they showed that by making the patient, those studies show that by cooling the patient down, so we typically cool the patient down into like the 32 to 34 degrees Celsius range, that helped improve neurological outcomes. So if you think about it, cooling patients slows down your metabolism drastically. So by slowing, and it also slows down your oxygen requirements, right? Your tissue oxygen requirements. So if I slow down my metabolism, I'm also not consuming as much oxygen. So that allows for that release of that free radicals and for those to kind of get processed in that brain tissue. And then the patient will hopefully have a better outcome and reduce the amount of swelling and brain damage that occurs. So they redid these studies back in 2015 and 2021. They did this comparative study, and this is where we really changed our verbiage more to that targeted temperature management, because we noticed that um, it wasn't really making the patient cold that benefited the patient, but making sure the patient didn't get hot. So I think most places are starting to adopt this strict normothermia range of looking to keep the patient at 36 degrees Celsius rather than making the patient cold to prevent brain damage. So that's that shift in things from more evidence, best practice, that we don't need to make them cold. We just need to make sure that they don't get hot. um, so if you're using therapeutic hypothermia and you're actually cooling your patient down, like I said, 32 to 34 degrees Celsius is the recommendation. And you maintain that temperature typically for at least 24 hours. A lot of times is even longer than that. I know some places do it for 48 or 72 hours, and then they gradually re-warm the patient back up, and then they do a bunch of neurologic testing to see what kind of brain function is there. So they'll take the patient to CT and MRI and see if there's been any tissue damage. And then they'll do like, excuse me, I yawned again, EEGs to look for electrical activity in the brain. Okay. We'll also talk when you get to mechanical ventilation about apnea testing, which is our role at the bedside for declaring brain death in patients. So, you might get their heart started back up, but unfortunately, if they've been down too long, they might not have a lot of brain function. And then we would do testing, neurological testing to determine brain death. So usually it takes 2 doctors to do that at the bedside. And then it's supported with a positive apnea test, which is a test that we do with patients to see if they have any brainstem or those basic involuntary brain functions that cause you to tell you that you're supposed to be breathing. And we'll talk about that more when you get to life support. So respiratory management of this, we want to make sure that the patient is ventilation and oxygenation is supported. So initially we're putting them on 100%, but then we're going to wean it down below 60% as quickly as the patient tolerates it. These patients are going to go on mechanical ventilation. We're going to adjust our vent settings to maintain that normal ventilation or normalize at CO2. We want to make sure that our ET tube is in the right position by checking with a chest x-ray. This is the time where we're going to assess cuff pressures and other things that we were too busy during the code to do. A lot of times we're going to get an ABG then to, within 30 minutes of putting them on the ventilator to assess oxygenation and acid-base status and make any adjustments that are needed. Cardiovascular management. Typically, these patients get followed up with some blood work. So typically, we're going to get a complete blood count, which is going to give us a red blood cell count, which tells us how well, our red blood cells carry our oxygen, along, our hemoglobin is included in our red blood cells. So we need red blood cells and hemoglobin hematocrit levels to know how well my patient's oxygen carrying capacity. My white blood cells tell me about infections. My platelets is my clotting factor. So CBC is always really important. A lot of times I will say if you're getting an ABG, you need to get a CBC because an ABG is only as good as how much hemoglobin. You can't really get a good picture of your oxygenation unless you know what your hemoglobin level is. So you at least need to add that hemoglobin onto most ABGs to really understand how your patient's oxygenating. Comprehensive metabolic panels. These look at electrolytes in your body. So sodium, potassium chloride, total CO2, which is your bicarbonate, albumin levels, which is a protein in your blood, bilirubin, calcium, glucose, all of these things kind of tell kind of your patient's overall well-being. And that also helps us do a differential diagnosis of what might have caused the cardiac arrest, what might be going on with the patient, or other issues, helps us identify other issues. And then as I said, you want to make sure you're getting a chest x-ray to look at your tubes and lines, making sure they're in good place, getting that EKG, 12-lead EKG, to identify any STEMIs or any other heart-related issues. Invasive hemodynamic monitoring, typically the patients either get a central line. At a minimum, I would say that they're going to get a central line. This tells me a lot. Central lines are very effective of telling me about my fluid status of my patient, so I can get a lot of information from that because it's going to read my CVP. Which tells me if I'm have too much fluid, not enough fluid, or additionally, I can get a Swan-Ganz catheter placed, which is a pulmonary arterial catheter, which you are going to learn all about when you get to hemodynamics in CP Phys at the end of the semester. So in labs, we'll talk a little bit more about these and kind of give you a preview to some of that information. But that is it for the very, very, very high level overview of ACLS. All right. Let me know if you guys have any questions.